Welcome to the deep dive. We're diving into some really interesting and, yes, pretty complex source material you've shared with us.
Yeah, definitely complex.
It's all about a condition called acquired portosystemic shunting APSS in dogs and cats.
It's definitely a topic with a lot of layers. Our goal here is really to break down the key points from your reading
Right.
so you can get a handle on what APSS actually is, why it happens, what it might look like, how vets figure it out, and how it's managed.
Exactly. Think of it like we're navigating the body's plumbing system, but where it's gone a bit sideways.
Good analogy.
We'll start with the basics, why these shunts even form. Then explore the signs, which can be pretty dramatic sometimes.
Yeah, they really can.
Then look at the sort of detective work needed for diagnosis
Yeah.
and discuss the different ways to manage these animals. Ready to jump in?
Let's do it.
Okay, so right off the bat, the material is clear. APSS isn't something they're born with. It happens later. So what is it, fundamentally?
Well, the absolute key thing is that APSS happens because of a pressure problem.
Okay. Specifically, it develops after something called portal hypertension, or pH.
Portal hypertension. They sound like high blood pressure, but just in that specific portal system.
Exactly. It's high pressure in that network of veins.
Right.
The ones that normally take blood from the stomach, the intestines, spleen, pancreas, and carry it to the liver first, for processing before it goes out to the rest of the body.
And the sources say this pressure can build up in different areas.
Yeah, that's right. Think of the liver like a big filter zone. The pressure can rise before blood even reaches the liver that's prehepatic,
Okay.
or it can be within the liver itself, causing issues there intrahepatic, or even after the liver when blood's trying to leave towards the heart posthepatic. Where the pressure builds really depends on the underlying cause.
So this pressure buildup, it's like a traffic jam, basically. And APSS is the body trying to build a detour around it.
That's a really good way to think about it, yeah. The APSS, these shunts, they are the detour. Vessels that shouldn't really be there, or at least not so big.
They open up to divert blood straight from those abdominal organs into the main circulation, completely skipping the liver's filtering job.
So it's a consequence, not the initial problem itself.
Precisely. It's acquired, not congenital.
Okay. So who typically gets this? The sources seem to point pretty clearly to certain patients.
They do give us a good profile.
Dogs with chronic liver disease seem to be top of the list.
That's definitely the most common situation described. Dogs with long-term serious liver inflammation or scarring, fibrosis, that kind of thing.
Right.
It's apparently less common in dogs with some specific congenital liver issues like ductal plate malformations, or maybe dogs who had surgery for a congenital shunt but didn't tolerate it well.
And what about cats?
For cats, the reading mentions specific liver malformations too, particularly one called congenital hepatic fibrosis.
Okay.
Also severe chronic cholangiohepatitis, that's serious liver and bile duct inflammation, though it says that's rare. And again, similar to dogs, cats that maybe couldn't tolerate surgery for a birth defect shunt. Oh, and there's a strong link mentioned with long-term bile duct blockage.
How long?
If it lasts longer than about 6 weeks, that seems to be a key time frame.
Interesting. And the sources also flag certain breeds.
Yeah, a couple. Persians and Himalayans in cats linked to those liver malformations.
Right.
And boxer dogs get a specific mention for a type of malformation too.
Got it. So let's talk about what this actually looks like. What signs would you see?
Well, the signs really reflect two things. Either the liver isn't getting the blood flow it needs, or the underlying liver disease has just damaged its ability to function.
And this is where things can get, as you said, really dramatic. The big one mentioned seems to be episodic hepatic encephalopathy, HEE.
Absolutely. That's a major one. It's all about the brain being affected by toxins that the liver should be clearing out, but isn't.
So what does that look like?
You see changes in behavior, neurological signs. They might seem confused, disoriented, stare into space, act very differently, or even show signs like blindness, poor coordination, stumbling,
Wow.
and other common things alongside that can be drinking and urinating more, not wanting to eat, being really lethargic, maybe vomiting.
And the most striking thing about HE, based on the reading,
It's that these often quite severe neurological signs can sometimes improve quite dramatically with fairly straightforward treatments.
like what?
Things like IV fluids with dextrose and potassium, certain antibiotics for the gut, a medication called lactulose, and changing the diet.
That temporary improvement is a big clue then.
It's a huge clue. Points strongly towards a liver problem being the root cause.
Okay. What other signs are mentioned? Ascites.
Yep, that's fluid building up in the abdomen. Common with the high pressure, the portal hypertension, although the amount can vary quite a bit.
And then there's this term, hypertensive splanchnic vasculopathy. Sounds pretty serious.
It is serious.
Wow.
Because of that high pressure in the gut's blood vessels, they can become fragile, they might start bleeding, or develop ulcers, especially in the stomach and the upper intestine.
And that's dangerous because?
Because it can lead to really significant blood loss, potentially life-threatening, especially if the liver damage also means they have problems with blood clotting.
Wow. And there's a double whammy effect here, isn't there?
Exactly. That bleeding into the gut can actually trigger or really worsen the HE.
How?
Because blood sitting in the gut gets broken down into substances like ammonia that are very toxic to the brain. And if the liver isn't filtering, well, it hits the brain hard.
So you'd see signs related to that bleeding too.
Yeah, like not eating, vomiting, maybe diarrhea, belly pain, and obviously signs of anemia from losing blood.
Okay. And finally, the sources mention urinary issues.
Yes, specifically related to a certain type of bladder stone, ammonium biurate stones.
Yeah.
These form because of the altered metabolism when blood bypasses the liver, so you might see blood in the urine, the animal straining or trying to pee frequently, maybe pain when urinating.
Okay, that paints a picture of the signs. But they sound like they could point to a lot of different things. So why does this happen? What actually causes the shunts to form?
Well, like we said, it all comes back to that portal hypertension, high pressure.
Right.
When the pressure builds because blood just can't get through the liver easily, the body seeks out detours. The sources point out something interesting. The portal vein system doesn't have valves like many other veins.
Okay, and why does that matter?
It means when pressure rises, blood can just flow backwards or sideways. It takes the path of least resistance.
Oh.
So it diverts away from the high-pressure liver through these other vessels, the shunts, that connect directly into the general circulation.
And what are the specific things listed that cause that high pressure, the portal hypertension?
The main one described is widespread scarring or fibrosis in the liver, sometimes progressing all the way to cirrhosis.
Okay.
That chronic bile duct blockage we mentioned, if it goes on for more than 6 weeks, that's another big one.
All right.
Other causes listed include blood clots blocking the portal vein itself, something called idiopathic portal hypertension, where they just don't find a specific cause. Certain liver diseases where tiny vessels inside get blocked, some specific vascular syndromes, and then less commonly maybe problems right in the main portal vein in the abdomen, like clots or strictures, or rare things like abnormal artery vein connections in the liver creating high pressure.
Got it. And those HE episodes, the neurological signs coming and going, what triggers those?
Yeah, the reading lists several triggers, things like a high-protein meal,
Okay.
bleeding in the gut, like we discussed, kidney problems developing, electrolyte imbalances like low potassium,
Right.
even things like blood transfusions, infections anywhere in the body, or sometimes certain medications can push them over the edge. Basically, anything that increases the toxin load the struggling liver can't handle.
And the bladder stones, that's directly linked to.
Exactly. High ammonia levels and other waste products not being processed by the liver lead directly to those ammonium urate crystals and stones forming in the urine.
So with all these varied signs, figuring out if it is APSS must be quite the challenge. How is it diagnosed?
Absolutely. It's real detective work. Because, like you said, the signs could be so many other things. You have to rule out other brain problems, different GI issues, urinary infections, other causes of stones, heart failure causing fluid buildup, the list goes on.
What about basic blood and urine tests? Any clues there?
Sometimes, routine blood work might show hints. Maybe small red blood cells, a mild non-regenerative anemia, sometimes weirdly shaped red cells, especially in cats.
And chemistry panel.
Yeah, often you see low levels of things the liver normally makes. Low BUN, low creatinine, sometimes low glucose, low albumin, low cholesterol. Liver enzymes themselves can be up, down, or normal, so they're variable.
And in the urine?
You might find those ammonium biurate crystals. That's a big clue, though they aren't always there. You might also see blood, white cells, protein, often related to the stones causing irritation.
The sources really seem to highlight one specific blood test. Total serum bile acids, TSBA.
They do. It's described as a very sensitive test for shunting, whether it's congenital or acquired. The key thing they emphasize is the pattern.
The pattern.
Yeah. The bile acid level might be sort of normal or maybe a bit high before a meal, but then after a meal, it gets markedly increased, often over 100, the sources say.
Why is that?
Because bile acids are released to help digest fat, and normally the liver pulls them back out of the portal blood very efficiently after the meal. If there's a shunt, they bypass the liver and stay high in the general circulation.
Makes sense. What about blood ammonia levels?
Also sensitive for HE, but the reading points out a practical issue. The samples are really unstable. You can't easily freeze them or mail them off, so it's often not routinely done. That's why finding those ammonium biurate crystals in the urine can be a useful indirect sign of high ammonia, especially if you check a sample collected after a meal.
Is there a better ammonia test?
There's something called an ammonia tolerance test, which is mentioned as reliable for seeing if the body can handle an ammonia load. But there's a big caution. Doing the test itself might actually trigger HE signs.
Oof. Okay. Good to know. Clotting tests.
Also important, they reflect liver function since the liver makes most clotting factors. And there's one specific test mentioned, protein C activity, which is apparently low when there's shunting, regardless of the cause.
And analyzing the abdominal fluid, the ascites.
Yeah, if there's fluid, testing it can help confirm it's likely due to the high pressure. Specifically, if the albumin level in the fluid is much lower than in the blood, a high serum to effusion albumin ratio, they call it.
Okay, so lab tests give clues, but you really need imaging to see what's going on, right?
Absolutely. Imaging is critical to look at the liver itself and, ideally, visualize those abnormal shunt vessels.
What can basic x-rays show?
They might show if the liver looks small, which is common with chronic disease, or they might show the fluid. Sometimes you can even see those urate stones, though they are often faint, radiolucent.
And the sources specifically warn against one older imaging technique.
Yes, they explicitly say radiographic portovenography injecting dye directly into a vein is not recommended now. Too risky, and there are better, safer alternatives.
Like what? What are the go-to methods now?
Abdominal ultrasound is a big one, very useful.
What can you see with ultrasound?
You can assess the liver size, its texture, look for fluid, look for stones in the bladder. But crucially, with color Doppler ultrasound, you can often actually see the APSS vessels themselves, these abnormal, tortuous vessels, often near the kidneys or spleen, and you can see which way blood is flowing in the main portal vein.
And that flow direction is key.
It's a major sign. If the blood is flowing away from the liver hepatofugal flow instead of towards it, that confirms there's high pressure and shunting happening.
Okay. Scintigraphy is also mentioned.
Right. That involves giving a radioactive tracer, usually rectally, and then using a special camera to see how much of that tracer bypasses the liver and goes straight to the heart.
And that tells you.
It's sensitive and non-invasive for confirming that a shunt exists, but, and this is an important point from the reading, it cannot tell you if it's a congenital shunt they were born with or an acquired one, APSS.
Got it. So for the most detail.
Multi-sector CT, computed tomography, is highlighted as the non-invasive method of choice.
Why CT?
It gives really detailed pictures of all the blood vessels, the liver structure, other organs, provides a great map. It's fast, but it does require general anesthesia and injecting contrast dye.
Okay. Do you always need a tissue sample, a biopsy?
A liver biopsy is mentioned as being really important for the definitive diagnosis of the underlying cause.
Not just for the shunt itself, but for why the shunt is there.
Exactly. You need to know what kind of liver disease is driving the portal hypertension. The sources say small needle aspirates usually aren't enough for that.
So you need a bigger sample.
Yeah, they recommend larger samples, like a surgical wedge biopsy or laparoscopic samples, ideally getting tissue from a couple of different liver lobes.
And what does the liver actually look like in these cases, pathologically?
Well, it depends on the underlying cause again. If it's chronic scarring, the liver might look small and irregular. If it's certain types of outflow blockage or maybe an AV malformation, it might be normal size or even enlarged, with portal atresia, small. And in cats with that specific polycystic disease, it might be normal to large with cysts.
Okay, so putting all that together, the signs, labs, imaging, maybe biopsy gets you the diagnosis. Step one. What about managing it? Sounds like it needs a multi-pronged approach.
Definitely. It's complex, given all the potential issues.
Nutritional support seems like a cornerstone.
Absolutely essential, yeah. The sources really emphasize a balanced diet, but crucially, it needs to be protein restricted.
But not just low protein across the board.
Right. There's a nuance there. You don't just pick the lowest protein diet. You have to titrate the protein level based on how the individual patient tolerates it. Meaning you adjust it carefully to control those HE signs, the neurological issues, without causing malnutrition. Find the sweet spot for that animal.
And the sources note a difference between dogs and cats here.
They do. For dogs, they give specific guidelines. Start at a baseline protein level, then gradually increase it every 5-7 days, watching for HE signs to find the maximum they can handle. Dairy and soy proteins are mentioned as good options for this careful titration in dogs.
But cats?
Cats are different. They're obligate carnivores. The material stresses they require meat-derived protein, so protein restriction is trickier and needs careful management.
And sometimes IV nutrition.
Yeah, if they're really sick and not eating, parenteral or IV nutrition might be needed temporarily.
Educating the owner sounds absolutely critical, too.
Oh, hugely. It's a chronic condition management. Owners need to be able to recognize the subtle signs of HE returning.
Right.
They need to understand the risk of those ammonium biurate stones causing a blockage, especially in male dogs. The source even mentions the potential need for a specific surgery, a urethrostomy, in some males. Wow. And owners often need to learn how to adjust medications at home, like diuretics for fluid, or maybe give medications like lactulose if HE signs appear.
What about specific drug therapies for that dangerous gut bleeding?
Yeah, managing that hypertensive splanchnic vasculopathy involves things like acid blockers, H2 blockers, or omeprazole and sucralfate to protect the gut lining.
And if it's severe?
Severe bleeding is an emergency. Might need hospitalization, intensive care, blood transfusions, maybe drugs to help with clotting like DDAVP.
Okay. And managing the acidates, the abdominal fluid.
That often involves diuretics. The standard approach mentioned is usually a combination of furosemide and spironolactone.
How do you manage that?
You monitor things like their weight, their belly circumference, their overall condition, and adjust the diuretic doses usually every few days based on response, trying to get rid of the fluid without causing other problems.
Other problems
like dehydration or electrolyte imbalances. The sources specifically warn about this. Because avoiding dehydration and avoiding low potassium is crucial. Getting dehydrated or having low potassium can actually trigger or worsen the hepatic encephalopathy. It's a really important balancing act.
Are there other drugs for fluid?
The sources mention that the albumin ratio in the fluid might predict response. For really tough resistant cases, there's a brief mention of other classes like ARBs or aquaretics, but furosemide and spironolactone are the mainstays.
Any other big medication considerations?
Yes, definitely. Because blood is bypassing the liver, drug metabolism can be really altered.
Oh, so?
Drugs that normally get broken down by the liver on their first pass might have much stronger effects or last longer. Protein binding might be reduced if albumin is low. So you have to be really careful with drug choices, doses, and monitor closely for side effects with almost any medication.
And specific drug interactions to watch out for.
The reading mentions avoiding metoclopramide with spironolactone because it apparently blocks its effect.
Yeah.
And avoiding NSAIDs, non-steroidal anti-inflammatories, is important too. They can interfere with furosemide, potentially hurt the kidneys, and cause sodium retention, which is bad for fluid buildup.
Got it. So once you have a management plan, follow-up must be ongoing.
Absolutely critical for these chronic cases.
How do you monitor them long-term?
A lot relies on the owner watching their demeanor and appetite at home. That's often the first sign HE might be worsening.
Makes sense.
Then in the clinic, you monitor the clinical signs we discussed: body condition, weight, belly girth if ascites is an issue, and repeat lab work, CBC, chemistry, urinalysis.
Urinalysis, especially for?
Checking for those ammonium biurate crystals to monitor the risk of stone formation.
And the sources had a really important point about bile acids for monitoring.
Yes, a key takeaway. Total serum bile acids are not useful for ongoing monitoring after you've made the diagnosis.
Why not?
Because they tend to just stay persistently high in animals with shunts, even if they're clinically doing well. And some medications can affect the results too. So you don't use serial TSBA tests to track how well the treatment is working.
Okay, so monitoring guides treatment adjustments.
Exactly. You fine-tune the diet, the medications for HE, the diuretics for fluid based on how the animal is doing. And you always keep an eye out for any signs of bleeding. Maybe even considering intermittent vitamin K supplementation if clotting is a concern.
Is there any way to prevent APSS?
Well, the main strategy suggested is really about prevention of the underlying cause,
Meaning?
meaning treating acquired liver disease or bile duct blockages early and aggressively. The idea is to minimize the liver scarring and fibrosis that leads to the portal hypertension in the first place.
Okay.
There's also a brief mention about being cautious with how congenital shunts are surgically treated, seemingly to avoid creating a situation where APSS might develop later.
Right. So finally, what are the potential complications down the road, and what's the overall outlook for these animals?
Complications remain a concern. That severe gut bleeding needing intensive care is one. Problems from the diuretics, dehydration, electrolyte issues worsening HE are others.
And the worst case.
And sadly, the potential for death is real, stemming from progressive liver failure, severe uncontrolled HE, massive hemorrhage, or maybe sepsis if things perforate.
And the prognosis. What's the expected course?
It really, really varies. It depends almost entirely on the underlying cause of the portal hypertension.
Okay.
The sources suggest that if you can manage the underlying chronic liver disease or fibrosis effectively, you can potentially extend life.
Any more specifics?
Yeah, there's a slightly more hopeful note for certain conditions. Animals with non-cirrhotic portal hypertension or specific ductal plate malformations. It says they may potentially live more than 8 years if, and it's a big if, their symptoms and complications are managed successfully through those symptomatic periods.
Okay, so let's just quickly recap. Acquired portosystemic shunting, APSS, it's a serious secondary issue. It happens because high pressure builds up in the veins going to the liver,
Right, the portal hypertension.
causing blood to take detours, bypassing the liver entirely. And this bypass leads to a whole cascade of significant signs, neurological problems, fluid buildup, bleeding, urinary stones.
Yeah, wide range. And diagnosing it takes careful work, putting together the clinical picture, the lab results, and really importantly, advanced imaging like ultrasound or CT to actually see the shunts and figure out what's going on with the liver underneath it all.
And while it's clearly complex, the management focuses on that tailored protein-restricted diet, medications to control the HE, the fluid, the potential bleeding.
And treating the root cause, if possible. And doing all that can make a real difference to their quality of life and potentially how long they live, depending on that underlying cause.
It really makes you think, looking at APSS, just how interconnected everything in the body is. You have this system, the portal system, designed specifically to filter blood through the liver.
This vital organ.
And disease can cause this backup, this pressure that leads to these dramatic bypasses. And it really underscores how signs you might otherwise overlook. Maybe just a subtle change of behavior or drinking a bit more water or, a cat having some urinary issues could actually be the surface sign of this really complex vascular problem deep inside. It's just a powerful reminder, isn't it? Not to dismiss those seemingly small changes, because they might be pointing to something much bigger.